Guys, welcome back to Medical Coding with Blue. Today's episode is all about outpatient medical coding productivity standards. If you're brand new to my channel, welcome. I am Blue. I'm a medical coder. Okay, guys. So first things first. Every place is going to be different. They're going to have different productivity standards. However, the numbers that I'm talking about today, sometimes for some places, this does not work for them and they're going to expect higher, but I'm going to get into why this is the average. This is what I have seen. Okay, so that's the first part. The second part is we are only discussing outpatient medical coding today. There is a different productivity standard for inpatient medical coders. The coders who are coding with ICD-10 PCS and they're doing DRGs and all that other stuff, right? That is something completely different from what I'm talking about today. I am talking about outpatient coding and the professional fee side of coding. So there's a big difference in those productivity standards, okay? So this is something that I want to make very clear. The other thing is this. People have been asking me, do you get paid by the chart? And when you say things like paid by the chart is something that we use when we're referring to inpatients, because inpatients have all of their encounters with the providers in a chart. In the outpatient setting, we are coding by the encounter. That's what we do. We have just a day that we're coding for, and we have to use that particular document that was documented on that day in order to be able to pick up like diagnosis codes and procedure codes. So that's in the outpatient setting. We cannot refer back to old notes because everything that is documented on that day is what happened, okay? Which is why consistency with documentation is so important, but that's something that you'll learn about later on. But just so you guys know, that in the outpatient setting, we only code what is done on that date of service, okay? And the diagnosis and everything, the procedures and everything, it's all on that day. We can't refer back, okay? It has to be on that day. So that I just want to make very clear. The other thing is this. This particular number that I'm going to talk about today in productivity rates is something that is attainable. This is something that I've had many jobs and they've all kind of fallen into this same amount of productivity. Now you're going to see when you're out there applying, especially in the outpatient setting, that there's going to be a variety, and there's a variety for many reasons. The easier the clinics and the more straightforward and the more mundane the clinics, sometimes the higher the productivity, okay? And there's a limit to that productivity without having it be data entry, okay? So if you're going really high, then that's just data entry. That's not even medical coding, okay? But if you are at a place and they say, well, we want 150 done average per day, that's something that's going to be like on the kind of repetitive side, right? A clinic that's like that. So that's what you want to kind of keep in mind when you're looking at the productivity rates or when you're asking them what their productivity rate is. You do not want to get into a place where the productivity rate is so high because you're not going to have time to look at the documentation. You're not going to have time to abstract and get all of these diagnoses or procedures because you're trying to rush. And keep in mind, everything that the medical coder selects is what gets submitted to billing. And once it gets billed, that's where the money starts changing hands. This is the difference between a provider and a facility and all these other people and these doctors being able to have staff and everything. Is a difference between them getting the right money or getting the wrong money and then having to pay it back with interest, and then all of a sudden it's just a big mess. So that's why you have to take your time into getting these charts, not charts, but these encounters coded. See, I'm thinking charts. But you have to take your time in order to get these encounters coded, but code them properly. So the average that I have seen on the outpatient side is between 80 and 150. Now this is the average per day. So not every day you're going to be able to hit these numbers, right? Just say for instance, your productivity is 90 per day. That's my productivity, because I code for a specialty clinic. I code for orthopedics and podiatry. And in my facility, that is considered specialty. So somebody who works in PT and OT is going to have a productivity of 120 per day, because they have a little bit more repetitive things going on, and there's just a little bit more straightforwardness. Whereas I have to work with E&M codes, I have to work with minor procedure codes and sometimes major procedure codes, and then all the diagnosis coding. So in other clinics, it may be a little bit more easier because they don't have the range of codes that I have to work with, okay? So that's just something that you got to think about. And even though you may not hit your productivity every single day, it's okay, because there's going to be days where you'll be able to do a lot more because the documentation is really good. Maybe you're working with a provider, or the CDI people are working with the provider, and everything is going like it should, and then the productivity goes up because you don't have to send queries, and you don't have to do all of these things that you would have done if there wasn't somebody else already taking care of all that other stuff on the other side. So if that's the case, then great, because your productivity can go up. But if you're struggling to meet your productivity, there's one of two things happening. Either you need more practice, or the provider needs education, especially if you're having to do like a lot of education type things. But if the productivity standard for where you are working is between 80 and 150, that is normal. That is something that is very good. That is giving the coder time to look at the documentation, to actually code it, because sometimes the encounters are already coded. Like the doctor will select their codes, and then we're just sort of auditing as medical coders. But doctors are not meant to be medical coders. So sometimes they don't always pick up the most specific code. Sometimes maybe because of the electronic medical record that they're using, they will select like an unspecified code, right? Instead of like right knee pain, they'll say unspecified knee pain. And then we go in and we select the code for right knee pain, because that's specifically what is in the encounter for that patient. So that's what we do, and we have to go in and correct. And that takes time to be able to do that. And sometimes they may not know that they coded for their documentation reflects a different procedure code. So we have to go in and make sure that the procedure code is appropriate to the documentation. And then, of course, with the evaluation and management leveling, if they get that for an encounter, then we have to add that. So again, all these things take time. And again, if you are in a place where it's between 80 and 150, that's okay, because it's something that people can attain, like they can hit those numbers, but they can also have the time to look at the encounters. Now, the higher you go in your productivity average, obviously, the more you're having to okay, there's going to be days where you're just going to be like right there at the computer and go, go, go. And then again, like I said, sometimes you'll get really good with good documentation to work with, and then the productivity just comes easier. So it really all depends on where you are. But if where you are, they say, well, we expect 320 out of our coders for outpatient, and it's for the ER. That's unacceptable, because 320 per day average means you're just data entering. You're not looking at the encounter in order to find out what they did and everything else, and you're trying to hurry up. And that, again, you're missing out on a lot, because how can you really truly look at encounters very well if you're being told that you have to do 320 average per day? And please don't comment and try to make it normal that, oh yeah, that's what I do. That may be what you do. But again, that's not coding. That is data entry. Because again, there's no way that you can sit there and go through all the steps where you have to figure out what the E&M level is, and you're not always able to trust what is pre-selected for you. Just because those codes are selected, it does not mean that those are the accurate codes. So if you are doing that, if you're saying, okay, well, the provider selected a level 3 for this, and he selected these diagnoses, and that looks good enough for me, so I'm going to go ahead and push it on through. It's all going to come back to the coder. And what did they code? So you would have to be able to explain if these encounters go to court, and you have to explain in the court, what was your reasoning for selecting these codes. You cannot just say, well, those are the codes that the provider selected, so I just pushed them on through. We, as medical coders, have ethical standards, and we have to make sure that we are coding properly. And the productivity doesn't matter at that point. Accuracy matters. That's why I say be very careful about where you get a job, because if your job is saying, well, we want 320 average per day for you medical coders, that's somebody that clearly does not understand what medical coders do. And if you are in a situation like this, I would seriously consider looking at other places to work, because I would not want to be in a situation where I'm having to be called to the carpet and being like, okay, well, why did you do this? Why did you select these codes? And I don't want to say, well, because I was rushing and I was forced to. No, not going to do it. I refuse. Because again, we are under ethical standards, and I love what I do. I don't ever want to jeopardize that because somebody's telling me I have to rush. There's no reason for it, okay? If they need more staff, then that's something completely different. That's not your fault. So again, look for a place that's going to have a comfortable amount between 80 and 150, because that will give you time to look at these encounters. And like I say, like a little bit on the higher side, the 150, you start hitting 150, 140, is because you're doing something that's like repetitive, like maybe like an immunizations clinic or something like that, you know, something that is very the same thing. Now, don't go looking for like repetitive places to work and things like that, because when you do that, again, you're not flexing that that mental skill with, you know, coding for evaluation and management and coding for different procedures and things like that. A medical coder should never get rusty on anything, okay? You know, I'm fortunate enough that I work in a clinic where I code for diagnosis, I code for major procedures, and I code for minor procedures, all right? Now, it may look a little different if you're coding for surgeries, okay? Obviously, between 80 and 150, that's too high for a surgery coder, because you're having to sit there and read op reports, right? So they're gonna be a little bit lower, you know, maybe between like 25 and 30, sometimes 40 at some places. So again, it really all goes back to where are you coding and how, you know, how have they managed their machine up until now. But again, be very careful when you're picking up codes, because you want to make sure that they are accurate. Again, everything, these procedures that you select, they're going to influence how much money that patient has to pay, or how much the insurance is going to have to pay to the provider, you know, on the patient's behalf. So you want to make sure that those are accurate. And even if you're at a place where they say, well, you know, we've already worked it all out, and these are the codes that we always get, and we submit these to insurance, and insurance always says that it's correct, so we always get paid. We never have had any issues. If you're not regularly checking just to make sure that everything's still hunky-dory, if you're not doing that, you could be in for a big surprise. Because when you think about it, these insurance companies can go back and they can they can do a random audit and be like, you know what? You owe us money because you were taking this money because we paid you, but you could have been doing your own audits, which, you know, offices are supposed to do your own audits, and then, you know, self-report like, hey, we messed up here. You know, we're giving you your money back. That's a lot better than them finding it, okay? So you have to make sure that everything that you're picking up is accurate, and you need the time to do it. Now, there's greedy people out there, meaning like administrators. They know who they are. They think that, oh, medical coders are just data entry people. No, ma'am. No, sir. You clearly do not understand what we do if that is what you think of medical coders. And there's a lot of people who think that they know and they don't know. There was an article by a certain CEO that was talking a lot of mess about medical coders. And unfortunately, it shows his ignorance, because he doesn't know what we do, clearly by his words in this interview that he did. But again, you know, there's people that think they know what we do and they have no idea what we do. So be very mindful of that. When it comes to productivity, yes, it is important. But you know, building these relationships with these providers and, you know, getting these queries when they're appropriate, and providing the providers education on a regular basis so that they are up to date on the latest and greatest is going to keep them documenting so well that you will be able to pick up your speed in coding because everything is there like it's supposed to. This happened a few years ago when I first got into orthopedics. Okay, so we had a lot of work to do. We had a lot of new providers that came in and coming in from different hospitals, and each had different training, and some were just out of residency. So they had spent their time being, taught with other, senior surgeons, I guess you would say, and or attendings, there we go, attendings. And so they had basically taught them, but they didn't know anything about coding. They knew that, oh, well, I have to select the codes for the medical biller coder. So, okay, it was a lot of like, okay, no, let's work this out. So everybody was taught differently, and you could see the ones that were taught, better, and you could see the ones that were taught not so good. And so it was all about like, okay, I had a partner at the time, and so we had to do teamwork because we were both struggling to meet productivity because of the amount of queries that we had to send. So we both put our heads together. We're like, you know what? We need to get on their calendar and we need to start doing some education with them, like as a group. So that way everybody can get on the same page. So we started doing that, and we started doing like a coding tip of the week, and we started like sending out just like a little snippet of like just something really quick, really fast for them, so that they had little, tiny bites of information, and they loved that. They really did. And so that's the thing. Once all of that started going into place, then the amount of queries that we had to send lessened because everybody knew when you're seeing a patient for a post-op, you need to put the date that you had the surgery for that patient, what the patient had a surgery for, whether it was an injury or if it was an organic condition. You need to list that so that we know which code to pick up in the post-op period, right? We need to know what you did, if you changed a bandage, if you removed sutures. You need to be able to document all of that, and patient tolerance and all of these things. So that way we don't have to sit here and keep querying you. Well, as we did that, all of that got straightened up. And so we went from hitting 90, all of a sudden we're able to hit 120, because just me and her on average, because even though our productivity is 90, we were able to go up because of the good documentation. So if you take the time to do good documentation, the productivity will go up because it'll be a lot easier and quicker to go through. And then all of a sudden we didn't have to do queries because everything was there. And it was the very rare instance that we had to do queries. Okay, because everybody needs to know that queries do take time. I told my providers the anatomy of a query is 1 hour. They go, what do you mean, Blue? And I said, if I have to sit here and go through the query process, it takes me about 10 minutes, 15 minutes, right? Because I got to go and identify the error, and I've got to get it into either the template or I have to draft it out myself. And then if I have to draft it out myself, you have to give them options, and you have to be able to write it in the appropriate manner so that it's there correct, and everything. Then you got to send it to them. Then you got to wait on them to respond. And then sometimes if they're feeling feisty, they'll be like, oh no. And they'll come back with some response. And then you got to go back and you've got to explain to them why is this, and this. And as far as like, this is why there's a question here because of this conflicting documentation and this conflicting documentation in the same note. That's why. And so then they're like, oh. So again, there goes an hour, because do you think about it? 15 minutes to do that, 15 minutes for the response, 15 minutes for a rebuttal, and then 15 minutes for actually like sitting there correcting it, and then, oh yeah, it's done. And that's if they tell you, because sometimes they won't tell you that they corrected it. You got to go back and look to see if they responded to the query. And so that's an hour. that you spent for one. And so once I explained that to them, they were like, okay. They were a little bit more responsive after that because, they didn't really think about it from our perspective as coders, okay? Everything impacts our productivity. But if you can get to the root cause of that problem that's slowing you down, whether it is that they don't understand the fundamentals of when they're in the post-operative period, or they're not documenting everything on a procedure so that you can get the appropriate code. Like say, for instance, there's a laceration repair and you don't know how deep those layers are going. You have to go default to the lowest level one. I mean, again, and you can see in the documentation that it's complicated. That's when you have to query, guys. And so again, it goes back to them understanding, okay, these are the things that we see in this documentation. And this is why these things are important, because we need to know, what was this patient here for? And we need to know how did you take care of them, right? And so it's about clarifying the documentation. It's not about, this money. Money is never talked about in these situations. Never, okay? Because that's unethical. But once the documentation is good, then you don't have to worry about money, because the money will naturally come to you. Because again, you've done a good job documenting, so it's clear on which codes should be selected, right? So that's the thing. And then again, productivity goes up. And so that's a wonderful feeling. It's truly a wonderful feeling. And so when my partner and I were doing all this education, and then we got to that point where it's just like, okay, let's see if we can knock everything out in a single day. And so we were able to knock everything out in a single day, which was incredible. Instead of it taking a couple of days, 2-3 days, it was being knocked out in a single day, because the documentation was so good and everything was there like it should have been. And there was no question about what was going on in that room. And it was like, yes, this is awesome. This is amazing. And to see that productivity go up and to see, everything evolving like where it should, that's the beauty of being able to hit and meet and exceed those productivity standards. But again, like I said, if you're out there and your facility is 90 and you're struggling even to meet 90 because there's so many queries, get to the root of the problem, right? Because I know it's something completely separate with queries and talking to providers and doing education from productivity, but it does relate. Because if the documentation is good, then you won't have a problem meeting productivity. If the documentation is terrible, then you will struggle to meet productivity. So that's just something that you all got to keep in mind. But go to a place where it is realistic on those productivity standards. I can't tell you what to do as far as don't quit, okay? Do not quit your jobs out there. I'm not saying that at all. You always want to make sure that you have another job lined up. But, if your productivity is 320 and you're stressing and you're saying, oh my gosh, this is horrible. Why did I even get into this? Because that's data entry. That's not medical coding, right? So make sure that you get to a place where they can appreciate your talents and know what you're capable of. Because even though that productivity standard is at 90 or 120, but you do really good with the documentation review and everything else, and you're starting to, make sure the providers are educated, that productivity is going to be easier to hit. I'm just saying. So with that said, I'm going to go ahead and wrap this one up. Thank you guys so much for joining me this week. I will see y'all again on Monday. If this video helped you, please like, subscribe, and share, and I'll see y'all next time. Bye.